Hi, this is Brian Kim. I'm going to share with you this case of a patient with a very tiny, small pupil, and the patient also had weak zonules, and so I decided to place iris hooks. And so you'll be able to see the case goes fairly uneventfully, and as I'm doing I&A, you'll see a sudden anterior capsule tear. And so it just goes to show these patients with small pupils, again, tend to have weak zonules and obviously weak capsules as well. And so you'll be able to see what happens and how we handle this anterior capsule tear. So I use a cotton tip to steady the eye, and then using a corneal marker to help me center and size the rhexis. And then I make a subincisional episcleral stab incision, and I'm going around making my cataract incisions as well as my incisions for the iris hooks. I like to place one subincisional and then 4 extra ones circumferentially. I'm injecting some intracameral lidocaine and then some intracameral epinephrine. You can see there is absolutely no response with the epinephrine. This is some dispersive viscoelastic to coat the cornea and to viscodilate a little bit. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then enter. Place my iris hooks now. So I start with the subincisional hook, retracting the stopper, rotating the tip downward, using the stopper to dial it, and then cinching it down. Same maneuver for each one, retracting the stopper, rotating the tip down, and then anchoring it down. So once you get really comfortable doing iris hooks, it really doesn't take that long. You just retract the stopper, rotate the hook down using the stopper, and then cinching it down. And so you have exquisite control of the iris because it's secured to the scleral wall. If you have a ring, it's going to be secured within itself. But if the pupil itself is unstable, then you're going to have a ring that potentially moves around. It can move side to side and up and down. Whereas if it's secured to the scleral wall, it's not going to move or change. So I push some more viscoelastic to flatten the anterior capsule. And then we're going to try with the forceps here. I'm going to puncture the center, which actually does work. The tear goes a little bit funny there. Go ahead and grab it. Try to start the tear, which goes nicely here. I have the cannula there just in case I need to push some more viscoelastic. And then there's the rhexis, it's finished. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally into the fornix, point the tip down, get a nice wave, decompress on the left side, dissecting the anterior capsule there, and then going to the other side, pointing the tip down, and you can see the lens begins to spin. Irrigating the surface of the cornea, adjusting the sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. You can see I haven't really dilated the pupil that much because I don't want to damage the iris. Placing the chopper under the rhexis edge contra-incisionally, the ficcative vertically sub-incisionally. Crushing the lens in half, that's double chop. Placing the chopper around the right heminucleus, pulling it centrally to divide the right heminucleus. All of this is with mechanical forces only, with no ultrasonic energy or vacuum. Using some high vacuum to remove some of that lens pieces. The lens is not wanting to spin, just very gently turning it, placing the chopper around the lens piece, and then dividing that lens piece in half. Again, this is not really a super dense lens, but the pupil was very small, and I suspected the patient had zonulopathy as well. Placing the instruments around the lens once again and crushing it and dividing it in half, and then using high vacuum and crushing forces to remove the lens pieces with a little bit of vacuum as well. This is the final quadrant, getting around the lens and then grabbing it with a little bit of vacuum, crushing it and dividing it, and then emulsifying the lens pieces. So the last piece, making sure it's separated from the capsular bag, crushing it into smaller pieces, using the vacuum to grab it, and then using some more crushing forces to emulsify. There's a little bit of epinucleus that's attached to the bag. I'm able to grab the anterior part of it. I'm able to hook some of that material with the chopper. But rather than perseverating, I decided to come out with the chopper, push BSS in, take the phaco tip out, and go in with the I&A handpiece. So I plan to go after that material with the I&A. Start sub-incisionally, and then going around and removing the remainder of the cortical material. So I go ahead and start polishing underneath the rhexis edge. Polishing mode is very, very gentle. It won't cause any zonular stress or damage as you go around. It's unlikely to grab the capsule and cause any issues. You're able to polish underneath it in a controlled manner. And it looks like a fairly clean bag. So I'm polishing on the posterior capsule surface a little bit. So I'm pulsing into the subincisional capsular fornix, and it starts to liberate some more lens material there. And you see, as I do this maneuver, I'm fairly aggressive, turning that I&A tip subincisionally. But as I do this, I notice something. So wait a minute, is that an anterior capsule tear? How in the world did that happen? And so I was rewinding it in my mind, and I don't think the cannula did that. I don't think I did that during phaco. It must have happened while I was sweeping. So that was a little bit strange. So I'm mindful of that as I push cohesive viscoelastic into the bag, making sure the eye doesn't decompress too much. Don't overfill the capsular bag, which could propagate that tear even more. I do believe that the anterior capsule tear is only localized in the anterior capsule. There's no real reason for it to have radialized because there's no other forces that would have caused that to happen in the subincisional space. So I go ahead and proceed with the single piece acrylic lens into the capsular bag. And now I'm going to very carefully, with the cannula, disengage the haptics off the optic and then dialing the haptics and rotating the lens in such a way that the haptics are not going to be in the area of the anterior capsule tear. Now, once I've done that, I'm going to have to remove each of the hooks, which is easy. You grab the part of the hook that's just distal to the stopper, retract the stopper out, and then disengage the pupil from the hook, and then twirl the hook up, and then pull it out. So I go in with the I&A handpiece, activate irrigation, go underneath the lens, tilting it, removing all the viscoelastic from within the bag. And it'll be important for me to keep the haptics perpendicular to the anterior capsule tear here. So you can see I did a very gentle surgery, but despite that, you can see the irregularity of the pupil edge from the iris hooks. And you can see there's some fraying of the pupil edge due to the iris hook. So again, that is one of the reasons why I try to avoid using devices whenever I can. But in this case, of course, I had to use the device because the patient had weak zonules. And you can see these people with weak zonules, and in this case, a thin capsule. I was polishing, even though I'm pretty aggressive with it going sub-incisionally with the I&A tip, I've never actually expected the anterior capsule to split. So thankfully, the anterior capsule is right there. It looks perfect. It's well approximated. I do not feel like the tear has propagated posteriorly. The lens is in perfect position, and I was able to take this potentially challenging case and make it a routine case with the iris hooks. And again, iris hooks are very easy to do. You have good control of it because you're securing the pupil on the scleral wall. And, the hooks are reusable, which is also a nice feature. So this patient had double chop, cross chop mechanical fracturing techniques, very careful lens disassembly, gentle phaco with minimal stress on the zonules as well as minimal trauma to the cornea, and the patient did well. So I hope this was helpful to you, and I thank you for your attention.